My name is Dr. Jill Simmons. I am a pediatric endocrinologist at Vanderbilt University Medical Center in Nashville, Tennessee. I am director of the Pediatric Metabolic Bone Disorders program here at Vanderbilt, and I have been working in the field of rare metabolic bone disorders for about 20 years. And certainly as part of that, I work with patients with XLH, primarily in the pediatric age range, but also some young adults. And I provide clinical care, also participate in clinical research and clinical trials, as well as this particular patient survey that we're going to be discussing today. So XLH is short, I should say, for X-linked hypophosphatemia, or what we will often call it in pediatrics is X-linked hypophosphatemic rickets, because in the patient population that I care for, often it causes some specific skeletal findings that manifest as rickets on X-ray. It's a genetic disorder. It's considered a rare genetic disorder, probably occurring in somewhere around 1 in 20,000 to 1 in 50,000 patients in the world. And it's caused by variants in a gene called the PHEX gene, which is short for phosphate regulating endopeptidase homolog X-linked gene. So I will call that PHEX from here on out. That gene defect causes chronic inappropriate elevation of something called FGF23, which is the phosphate regulating hormone fibroblast growth factor 23, which works to regulate phosphate metabolism, particularly in the renal tubules. It's a quite diverse disorder and certainly affects patients across the entire lifespan, in some ways similarly as you age, and in some ways a little bit distinctive as patients get older. And so in our younger kids, we will often see them around the time that they are starting to walk, manifest as bowing of the lower extremities, because essentially, if you think about it, their bones are not mineralized normally, and so they will sort of bend outward as children start to walk. If we look at them on x-rays, we'll find evidence of rickets and their metaphyses of their growing bones, particularly in the lower extremities, but we can certainly see those in other aspects as well, particularly in their wrists. We'll notice these things as skeletal manifestations, but these patients also have some other abnormalities. So they will often have delayed motor skills. Typically, they'll walk a little bit later, and that's maybe due to a combination of things, including that lower extremity bowing, but also maybe some muscular weakness that may occur as well. They'll have short stature. They often have dental issues, in particular dental abscesses, but also some mineralization or enamel defects of the teeth. And then as patients grow, they continue to have those manifestations of the lower extremity bowing if those were not corrected surgically or managed medically. They will have continued complaints of pain, which is something I didn't really mention in the pediatric population, but certainly occurs across the lifespan, particularly lower extremity pain and weakness. Adults will often have poorly healing fractures or pseudo fractures or stress fractures that may cause them additional abnormalities. They'll continue to have the manifestations of the short stature. This was a collaboration between the XLH network and Kyowa Kirin. It was really about better understanding the lived experiences of patients with XLH. The survey itself was really created to explore 3 specific areas. Number 1, looking at access to quality expert care in patients across the lifespan. Number 2, to investigate the physical, mental, and social impacts that these patients may experience, and also to explore the cost of living with XLH. So what happened was patients and or caregivers of children were asked to complete a survey, and then they were also asked if they would like to participate separately in a qualitative discussion-based interview to really delve into these issues slightly more. So to sort of tell you a little bit more about it, 85 individuals participated in this survey. Of those, 56 were adults, 29 were caregivers of children with XLH, and then 2 children themselves who were in the adolescent age range did participate in conjunction with their parents. And then of those, 36 agreed to participate in the adult age range in that additional qualitative 1-hour interview, and 20 caregivers also completed a 1-hour follow-up interview. I think that what we learned in the survey was largely a number of things that I hear about in clinic, but it was nice to hear about it in a larger patient population and really be able to explore some of the correlations between symptoms that patients would describe. So I think one of the things that was really interesting to me was learning that, and unfortunately learning that pain is a really significant problem in the majority of patients, whether they were pediatric patients or adults. And I think the other thing that is really important to realize is that this concept of medical trauma is pretty devastating to a number of people. And I personally am just learning a lot about what this terminology of medical trauma means. But many of the adults have experienced numerous surgeries, for example. In addition, a number of patients really had significant complaints about difficulty falling asleep or staying asleep or just sleep complaints in general. And I think that was perhaps something that I don't typically ask about in my patients in clinic. And so that was really eye-opening for me. And then when we really looked at it to try to say, okay, what are the associations here? The unfortunate thing was that patients who related pain or sleep as having higher impact tended to also have other psychosocial issues, particularly mental health complaints or effects, than those who had lower pain or lower sleep effects. So in other words, I think there really is a combination here of pain and sleep having an effect on the mental health of patients with XLH. Moving on outside of just the mental and social burdens, but thinking about some of the other reasons why we did the survey, we were looking at access challenges or access to care. And perhaps not surprisingly, a number of patients really do have to travel quite a long distance to find a provider who knows something about their XLH and is able to help them care for their XLH. So on average, participants traveled 180 miles and more than 3 hours round trip to reach a provider that was knowledgeable in XLH. And who those providers were is really quite diverse, ranging from geneticists, primary care providers, endocrinologists, as well as orthopedists. Also finding a dentist that was willing to learn about and understand and really help them with their XLH is something that was mentioned by several. That being said, the patients really did note that their dentists and their medical care providers who were willing to learn about the disease, even if they sort of went into that relationship not knowing much about it, was really impactful for them and something that they really were appreciative of. So not everybody knows about XLH, but many providers were at least willing to learn, but even so, quite a long distance to travel to actually access those providers. And I think the third thing that we learned about that really, again, wasn't terribly surprising, but is still a bit disheartening, is the challenges that patients face when it comes to transition of care from childhood into the adulthood space. And unfortunately, of this survey population, only 6% actually reported that they had formally transitioned from pediatrics to adult care. And when exploring a little bit more about why that is the case, the bulk of the respondents stated that they were just told they were going to grow out of their disease. That being said, that adult population had a mean age in the mid-50s. I'm hopeful that that transition of care is getting better if we look at a population that's currently transitioning from that adolescent to the young adult space. And so many patients look around, and although they may live somewhere remotely near a pediatric specialist who knows something about XLH, they may have a bigger challenge with finding an adult specialist. There's also lots of insurability difficulties with transition of care. Our young adults often are going into college or taking upon roles in the working world that may limit their access to care due to high cost insurability. And I think those are issues that are true across the rare disease space. And so something that we have to continue to think about when we think about managing these patients across the lifespan. I mean, again, I guess I already mentioned this really complex, or maybe not so complex. Maybe it's sort of a no-brainer. We would have expected this interplay between pain and sleep and mental health. And I think that's true for what we're finding, at least in this survey with the XLH population, but is, something I think as healthcare providers we need to think about in any patient who's experiencing a lifelong medical problem. And we really need to be really cognizant of asking the right questions and then knowing how to help them seek the right care for those complexities that may or may not be managed by the treatment of their actual disease process. So we need to ask the right questions, and then we need to know what to do when we get those answers. Because as an endocrinologist, I certainly don't treat mental health, but I need to make sure that my patients are able to address all the aspects of their medical care, whether or not it's within my specific specialty. I think that something I didn't mention a moment ago that I do want to point out is the hearing difficulties in this patient population was also a bit surprising to me. It's been reported in some other surveys and some other populations that in the adult space, maybe 50% of patients have some hearing difficulties. But in this particular cohort, it was pretty striking and something that I think we need to make sure we're really screening patients for, even into the pediatric space, because that can affect their learning abilities at school, their speech development, et cetera. Certainly much less likely to have been reported in the pediatric space, but there's still something like 5% of pediatric patients who reported some hearing difficulties, and somewhere closer, like I said, to 80% of adults, and with tinnitus being the most common difficulty, but actual hearing loss as well. And I think, again, as I think about other things that I learned from the survey, just as a provider, realizing that patients are spending quite a bit of money out of pocket. I guess I didn't really get into that with some of the survey results, so that's important to explore as well. There are quite a lot of out-of-pocket costs. It was really, really widespread, so it's hard to know. Upwards one family reporting up to $40,000 was spent in 1 year. That was, I think, due to a little bit more modifications that were required in the home. But the median amount of money spent out of pocket for these families is around $2,000. And that's a substantial amount of money. And that doesn't take into account things that maybe didn't happen, that they couldn't afford to pay for, perhaps particular dental procedures that may or may not have been covered by their insurance. And so they didn't even explore those out-of-pocket costs, or explored them and didn't report them because they weren't actually spent, or modifications of the home that maybe can't be done because they're just too much money for a family to be able to explore. And then you think about the travel costs. So not only is it time away from work, time away from school, but there's actually true money that's being spent getting in a car, driving 3 hours, perhaps each way, just to get the medical care that you need. So I think cost is something that I certainly can't fix, but something that I need to be cognizant of as I think about patients coming to see me, and are there opportunities for me to let them explore telehealth options and maybe getting local labs, et cetera. I think may be really helpful for some of these families when it's available. The transitions process is really important, and I'm fortunate here at my own institution that we do have a really good transition opportunity. I have a specialist that is really a dear colleague of mine who sees adults with XLH, and so we have a really nice opportunity to provide transition of care. But that's really still only true if the patients are staying as they move from childhood into adulthood, if they're staying in our local area. And even then, because of the insurability, et cetera, other things that people are dealing with, they still, even in sort of the best case scenario, which is what I would say I would think we have because of what I just explained about having somebody here who also takes care of adults with XLH, we still are not perfect at this transition process for a variety of reasons. And I think just as a memory, or reminding myself and reminding all of us as care providers that this is not a genetic disorder that ends when childhood ends. This is something that continues to affect patients in lots of really important ways as they go through adulthood and as they try to, successfully achieve what they want to achieve in life in terms of their own families, their own career opportunities, et cetera.